Welcome, everyone, and thanks for listening to Sports Doc Talk. I'm Will Sanchez, along with our orthopedic surgeon and sports medicine specialist, Dr. Garcia. Dr. Garcia, I had everything planned out for this show, right? We were like, we're going to do a show on Aaron Rodgers. We're going to talk about his Achilles and the procedure and who he went and how he went into the darkness, is going to come back in 3 days and rise again for the New York Jets. But we'll get into all of that. Unfortunately, we've got some really bad news, and we know how difficult, how beautiful the sport of football is, but at the same time, how difficult it is. Nick Chubb had an injury tonight. We're doing the show Monday night. Dr. Garcia, when you saw the injury, you heard about what happened to Nick Chubb, what was the first thing that you thought about? And let's get into what type of injury this is.
So, I had my usual friend group, and I saw all of a sudden get text blowing up saying, do you see what happened? Do you see what happened? And looking at the injury footage and then hearing from multiple people. It's only been injured for less than an hour, and I've heard from about 6 people asking what happened. So obviously this is a pretty hot topic, and people want to know because he's a very high-profile player with a pretty bad injury. So basically had a knee dislocation. And in isolation, this is really not a good thing. For me as a sports surgeon, that is the last thing I want to see on the field. There's obviously severe neck injury with paralysis. We don't want to see that, or, the Demir Hamlin injury, but those are really rare. This one's not as rare, but fairly rare. We've seen a few players with it. But having a knee dislocation is just awful. It's one of the worst things we can think of. And there's been a few players that have had this, but unfortunately for Nick Chubb, this is actually the second injury of knee dislocation on that same knee, which just makes this a whole other level of problems. But basically, if you look at it, and again, I'm not there examining under MRI, but if you see it in slow motion, it's pretty obvious what happened. You can see he tears his MCL, which is the ligament on the outside. Almost definitely tears his PCL, which is the ligament on the inside. That's the one you hear about less. Probably tore his ACL. His posterior corner, or LCL, which he had reconstructed in Georgia in 2015, may be okay, but this is considered a grade 3 or 3 ligament dislocation. And the other concerning thing is an injury to his artery, which I know there was a Bears player, or one of the players about last year, that had to get rushed emergently to the operating room because he had an injury to his artery. So this is a bad combination of things, and we'll obviously see how it unfolds. And I just hope that this obviously is not the end of his career, but also that he can, there's no major arterial damage, and they can protect him. And they will. Again, with NFL, we've seen them. They can do things that most places, if you got injured on the field, you wouldn't be able to do. So I do have faith that they're going to get that done.
All right, I have a question here. So just kind of going back to let the listeners know, you mentioned in 2015 as a sophomore, when he was still attending the University of Georgia, he dislocated his knee, tore the MCL, PCL, LCL in the same left knee that he had the injury tonight. If you're a physician, if you're running out in the field to treat him, what is one of the first things that you need to do? Because obviously there's some, besides the physical trauma, what's happening emotionally, because this is such a serious injury. So you have a team go out there. What are some of the first things that you have to concern yourself with, the player and the injury at the same time?
Well, let's assume they saw the footage before they went out there, or they saw the knee injury itself. And they might not have when they ran out, right? Because he goes down, says he's injured, and then now you're seeing the game footage on the screen or on ESPN, but that was the zoomed in one. Yep. Let's say they saw the footage. The first thing I'm worried about is the state of his leg, because I've seen in residency and things like that, injuries like this where they go unattended and you have a major problem because you've lost arterial or a supply of the blood to the leg. So the first thing I'm running out there doing is obviously making sure that it's relocated so the knee's in appropriate position. But the other important thing is making sure that there's a pulse in the leg. And you see that people check their pulse in their neck, in their arm, but you can also check it in your feet. And that doesn't give you the whole story of whether this is a real injury. There's some other tests you have to do. But just checking for that initially is something that's important, and making sure that the foot looks like it's got some normal perfusion and not like all of a sudden it's becoming, pink or a different color. And again, really quickly it just happened. So it might not have happened at that moment. Yeah. But that's the first thing I'm checking. And then I'm getting him off the field as soon as possible.
when it comes down to this type of traumatic injury, right, and whether it's the femur, the tibia, whatever that's no longer connected to the knee, and it's, for lack of a better word, it's not funny, but it's one of those words that is used, dislocated knee. It doesn't sound bad, but then obviously when you describe what the injury is, it's really bad. What is the concern, and how do you check for possible nerve damage in that immediate situation? Or is that something that you have to do when you get back to the locker room? What's that concern like, and how do you recognize it immediately?
So damage to the nerve is usually on the outside of the knee. There's a nerve. You can have damage to the other nerve on the inside of the knee, but that's a lot less common.
Okay.
But damage to the outside of the nerve was what you've probably seen someone that wears a brace called it's like an AFO or something where it keeps the foot from slapping. Mm-hmm. So the nerve that lets your foot lift up can be injured in this type of injury. Nick Chubb probably didn't have it at the initial time because obviously he wouldn't be the level he is right now. But that can happen, and that's a big deal. I've seen that before a number of times with these massive knee dislocations. So you can have a nerve injury and you can have an artery injury. The nerve injury is a bigger problem in the long run, right? Because sometimes it doesn't come back. But the artery injury, the nerve injury, if it happens and you notice it, there's nothing you can do at that moment as long as you've relocated the knee. The biggest thing is to get the patient's knee or to get the player's knee in alignment and get them checked out to make sure it's not an injury to the artery. That's the number one thing to do right now.
All right, and the last thing before we move on, just because I'm just fascinated by this type of injury, and I can't imagine going through something like that. How do you deal with the dislocation? Is that something that you're going to deal with before you go to the hospital, that you have to pop it back in place or move it in place? I'm probably not saying it correctly as far as you saying the word pop it.
Those are good questions.
But, how do you deal with that? Because this knee is out of place, and I'm assuming that this is extremely painful. So
the answer to that last question is yes. But the problem this is a second knee dislocation, right?
Yeah.
Because when you tear 3 ligaments, usually the whole knee dislocates. Now, this is quite bad. It went backwards. You could see it just completely go in a different orientation and bend in a way it's not supposed to go. And so he's gone through this before. And this may be one of the reasons it dislocated like this, because the ligaments you make, in theory, they're stronger, but they're always at a little bit higher risk. And once you've had damage to your ligaments and things like that, you're at a higher risk. Now, again, he hasn't gotten injured or had significant injury like this since 2015. So he's done fairly well since his Georgia injury. So that's impressive. And I didn't realize he had dislocated his knee before until this happened, because you wouldn't expect a player of that caliber with this injury. So he's already proven he can do it. But revision surgery, we've seen with Odell Beckham Jr. with an isolated ACL revision, much longer recovery. And this is a bad one. I mean, this is the second injury of this caliber. We have to probably look it up, but I don't know of anybody that's had a second one in the same knee and made it back. But again, I have to do my research. But this is not the one that I would wish upon anybody. And again, we don't have the actual, maybe his ACL is okay, maybe it's his PCL and just his MCL, but to dislocate your knee that far back, usually you have to damage a number of ligaments. And it's going to be also tricky. I think, again, we don't want to make this podcast too long for the listeners.
Too late.
But the other problem you have to think about, yes, too late. This is complicated, but this is super interesting for people that want to know about it. So basically, this is a whole nother level of injury. If you want to talk about complex, like the guy getting this injury right now, and I don't know if they're in the Cleveland Browns stadium, if they are, because a few of my friends are
they're at the Steelers. They're at the Steelers facility. In fact, the fans did a good job and cheered for him, so it was nice. Anyway, go ahead.
Yeah, so there's some really good surgeons there at the University of Pittsburgh, and I imagine the surgeons for Cleveland are there also for the game, and so they're both going to go right now to figure out what need to do for him. You won't operate on everything right away because you don't want to do that, because there's this is a whole nother lecture we could do and talk on this, and we may want to add this as a talk later on. But basically, they want to stabilize him. It's the same thing as trauma. This is like a trauma to the knee. It's like a car accident, right? Like, you're not going to fix everything right away. Yeah. You're going to figure out, let's calm everything down and do the big stuff later. So let's not worry about the major stuff. But the problem you have is he's had reconstructions already of his PCL, probably his LCL, and probably his MCL. So he already has new tissue, either used from his own knee or from cadaver, but probably a combination of both. And so now where are you going to get it from? So he can't use his own tissue because a lot of it's been taken already, and maybe from the other leg. But do you want to do that in a running back like him? Yeah. And can a cadaver ligaments hold up in an NFL player? Don't know. So, this is and now he's got tunnels and probably hardware in there. And so this is not like this is a straight up simple, let's go reconstruct everything. They're going to have to figure out things to avoid because he's done some wear and tear on these ligaments over time. And it's not the same as your own natural ligaments. So this is going to be, and there are some really good surgeons at both those places. And he's probably going to get some second opinions very quickly. This is going to be a doozy.
All right, I'm going to apologize right now because I have another follow-up question, and I'm really sorry, but I've got so many thoughts on this. Will they consult the original surgeon? I don't know who it was, right, from Georgia or wherever he had his surgery. When it comes down to something like this, that they're going back in to refix something that was already broken and fix, would they make a phone call or, hey, like consult at all or go back and look at some of the old film to see what they're dealing with, before they jump in?
This is a great question. This is a revision question. So I do a lot of revision ACLs and revisions such as this level. I mean, this is a pretty unusual injury. But whenever you're doing a revision, you want to get data from before, right? Because they'll say they use something that's metal. You don't know how to take it out, right? There's hundreds of metal implants out there, and they're all require different screwdrivers and different removal devices. So if he's got a bunch of metal in his knee, and I don't know, I've never seen the inside, but if he's got multiple screws that are different sizes, it's like you go into a car, and you don't read the instruction manual. How do you take out the engine appropriately if you don't have all the right ratchets and the right wrenches, et cetera?
Oh,
so if this is something where it has that, this could be a whole nother level. Again, these guys are good. This is not something, you're used to going into the operating room, and if you have to kind of audible things, you will, but they're definitely going to consult previous notes. I don't know if calling the surgeon is something that they would always do because, how are they going to remember from 2015? Obviously, he's a big deal, so maybe they remember that surgery. But overall, we all use somewhat similar techniques. We have different variations, but, there's good ways to do an ACL. There's good ways to do a posterior corner. There's good ways to do an MCL.
Yeah.
And so if you do it relatively a good way, kind of what's going on. And a guy like him who was checked out a number of times during the draft, and each time he's gotten through physicals, his knee was checked out for quality. And so, I'm not super worried about that part. But yeah, they're going to do some homework tonight for sure. This is going to be an all-night event, at least preparing if they have to do anything for him. So this is behind the scenes. This is a whole nother animal. We had a lot of these Giants players that had these severe urgent injuries, and not even this level. And it was, this is going to go into the wee hours probably.
Man, wow. All right, we're gonna move on. I'm telling you, I could ask a bunch of other things, and we've done so many shows with new tech and everything else, and we're 2023, and this procedure happened in 2015, so I could imagine the changes from then to now, and going back, and whether they have to, like you said, finding the right screws, and you see whatever. I'm going down the rabbit hole. Let me move on. He's
gonna have a few internal braces if I have to make a comment about that. So.
Oh man, you just like saying internal brace because it gets me hyped, man. I get so hyped. Let's get right into it. Aaron Rodgers, man, traded to the Jets on April 24th, 2023. I mean, for every Jet fan, and I have a lot of friends that are Jet fans, they ran out and they bought tickets. In fact, my buddy's going with his son and his grandkids to the Jets Kansas City game. They got tickets because it was the kid's birthday, and everyone's excited, and HBO's like, we're going to put them on Hard Knocks, and the NFL's like, well, for opening night, we're going to have them play Buffalo Bills, division rivals, on September 11th, and that night, it's packed stadium. Aaron Rodgers comes out by himself, running out of the tunnel with the American flag, and it's waving, and the crowd is just rambunctious and just absolutely rock star atmosphere. The place is jumping. The Savior is here. We're finally going to win a Super Bowl after 54 years, going back to 1969 and Willie Joe Namath. And 4 plays later, Aaron Rodgers gets sacked. He stands up and he sits back down, and something is wrong. Before we get into it real quick, when you heard about what had happened, when I saw it was unbelievable. I couldn't believe it. But when you heard about what had happened, what was the first thought? Because you're a Giants fan, you're a football fan. As a fan, what was your thought?
As a fan, it was horrible. That's the last thing you want to do for a team that really needs the motivational boost. And, you think about what you want about Aaron Rodgers and other things he's done, et cetera. But that what he's brought to the team and what he's brought to the fans of New York Jets, and the fact that this happened so quickly after the first game. I mean, it's just frustrating as a fan of any team, and just you feel badly for the Jets fans, and you feel badly for him too, because this is not an easy injury to recover for. And I think he'll get back, but that's not why we're doing this show, is because whether or not we think he'll get back, we're doing it for the innovative tech that he was supposedly given.
Yeah, get into this orthopedic surgeon that had performed this surgery. He has a history of working on athletes and some notable ones. So can you talk a little bit about the specific doctor and the type of work and the type of players that he's already done some of these surgeries on?
Yeah, so I think the more important part of this talk is the behind the scenes, because this was no cakewalk to take care of Aaron Rodgers. And you probably heard that he texted the doctor right after he got injured, telling him, get ready, I'm getting operated on tomorrow, type of thing. So this is a guy with a speed dial to professional athletes at that level.
Wow.
So this is Dr. Neil Elitrosh. He is the team physician for the Los Angeles Rams, head team physician. He is the Grand Master of Curl and Job, which is an extremely prestigious LA fellowship. I actually had the pleasure of interviewing with him. He's a really nice guy and obviously, really well known. My most memorable post I saw of him was him with having operated on both Sylvester Stallone and Arnold Schwarzenegger in the same day.
Wow.
So this is the type of guy that we're talking about. He's done Saquon Barkley, Joe Burrows, Tom Brady, and he always is pushing the envelope too. You can see, he mentions the word internal brace a lot. He talks about Tom Brady, how he internally braces MCL to get him back when he had that MCL injury. And he does a lot of behind the scenes celebrities as well. But, if you look up at so many professional athletes, and he's always been a high level player in terms of, one of the cutting edge leaders, one of the leaders for the celebrities and for the athletes. But over the last 5 to 6 years, he's really taken off. And, he's really good friends with the CEO of Arthrex. And so he's done a lot of innovative things through Arthrex. Obviously, we've talked about them as an innovator.
Yep.
And so he's well known throughout the world. He's the Tommy John guy. He's the now knee guy. He's the shoulder guy, for Jacksonville. He's the one that did the 8 anchors on the quarterback he's the one that said, it was the worst tear I've ever done. And, ended up putting, 8 anchors in the shoulder of a normal human being is a lot.
Wow.
So, he's done every one you name. I mean, if you look up his type of injuries he's done, extremely prestigious. So Dr. Neil Elitrosh is the physician, and you'll probably, he may get consulted on this one. McGregor, when McGregor went down.
Conor McGregor from UFC. Yep.
Yeah, look him up. So my friend is a trauma surgeon at UCLA, did the surgery, but Neil Elitrosh was required to be in the operating room to do it as well. So Neil Elitrosh, I'm not sure he is an expert at tibial shaft fractures, but he was in the surgery because he's a celebrity surgeon.
Yeah.
So that gives you an example of how big a deal he is that McGregor wants you in the operating room.
All right, let's talk about this procedure, right? And, I was excited not about the injury, but the fact that they did this internal brace, and I went to look at it because I'm fascinated. I'm dying to do it on a patient. We got to find a way. I might have to go to a different country to get away with it. But they showed where they drilled in and placed internal brace and how they pulled the Achilles together to hold it in place. Just talk about that procedure. And I don't know, what are they calling this? The speed bridge for this torn Achilles?
Yes. So I will burst the bubble a little bit that this is not new. This has been around for a little while.
Yeah.
The word internal brace, which we've talked about, and please listen to our previous episodes about internal brace. Internal brace is where you do a bone to bone. So in this situation, he technically wasn't internally braced. But everyone loves that idea, and so now everyone's using it for anything. It's now a catchphrase. It should be your catchphrase, but nonetheless.
I'm going to get a T-shirt that says, I love internal brace.
I'll get you one. I need to get you one of
there
those.
You go.
So basically, he wasn't technically internally braced, because remember, the word brace is to sort of make it rigid.
Yep.
And you don't want to make the Achilles rigid because the Achilles has to stretch so far.
Yeah, you need that
so it's
flexion,
different
right?
Than
Yep.
Yeah, and again, you don't internally brace tendons, you internally brace ligaments. So ligament is the UCL. A ligament could be the ACL that you internally brace. The MCL is a ligament, but the Achilles is a tendon. And so by bracing the tendon, that would be very bad. So he technically wasn't internally braced. So the procedure that he had is called a speed bridge. We do it in the shoulder as well. I've done this in the Achilles before. It's a really slick way of doing it. And the thought process is that when you tear your Achilles, you split it mid-substance. Initially, the older way of doing it was to do it open. And then they came up with percutaneous techniques where you can do it through a small little incision, maybe like, the little bit longer than your thumb. And then you can connect them together and sew them. Well, the third way of doing it is the way that Aaron Rodgers had it, where you kind of say the bottom part's like pretty good. So you maybe put a stitch in that, but the top part's where the big part of the Achilles is. And so you sew that directly into the bone. So the fixation is much more rigid and you can move people faster. And there's a lower chance that they're going to tear out. So they built it into his heel bone, which is what you probably saw. And the speed bridges, it means it's a lot faster with no knots or anything, because the knots can cause injuries. Because one of the biggest complications of Achilles is to get an infection. And so that's why these percutaneous techniques have been invented, because Achilles were known for having problems with having wound infections. With these new percutaneous techniques, it's extremely low. And now you have this newer technique, the speed bridge technique, which fixes it into the bone, so it's a much more rigid fixation. You never want to really be repairing tendon to tendon together. That's why this newer technique is so impressive.
Your tendon snaps, right? So there's a part of it that's up and there's a part of it that's low, and they're not connected. So when they did this procedure and they're bringing them close together, are they just bringing it close together and letting the body heal itself because now they're next to each other? Or do they have to, at that point, kind of connect them?
So that's the best question you've asked tonight, and you've asked some good ones. So that one is the trick that people do, that even when I was learning this and we learned about this, it doesn't make any sense. So it's a lot of people can be treated without surgery with an Achilles injury. If you keep the person in the elevation, eventually the tendon will grow back together in some cases. So there is some data that you can do non-operative treatment, especially in patients as they get older. So the idea is that it doesn't have to be in the same, it has to be in the same zip code, right? Or maybe it's the same household.
Yeah.
And so we used to tie them together either with a big open incision or this percutaneous technique. But what I was saying before is they really don't care about that bottom tendon, and they just pull the thing down as close as possible and keep it rigid. And the idea is that by keeping that part rigid and stretched out, you don't have a likely chance it's going to pull off. You can start moving faster, and the little leftover tendon will heal back there, and eventually it'll be fine. And the first couple of times I did this, it was really weird because you're used to like repairing everything back together. Like you want to make things look perfect, right?
Yeah.
I'm an OCD perfectionist, and you have to tell them, no, don't worry about it. It's not a big deal. It'll be fine. And that's what these newer surgeries, you have to kind of come to the comfort level. And it's always these really big innovators that cutting edge that understand this and learn this and teach this and invent these techniques, understand ahead of time, and then you slowly pick up on them. But that's exactly the point. So it is a partial repair, but really it's just basically putting in the same household, and then the body will heal it because it's not moving, right? Because it's been braced down to the ground.
Are you doing anything, or you adding anything to that area to speed up the healing process? Besides, I'm assuming that they're going to put them in a boot, but is there anything else that they can do to kind of, we're in the same neighborhood, but we want you guys to be a little bit friendlier, quicker, and not just kind of bumping to each other in the street? You'd be like, hey, no, we're putting you in the same place.
So they're probably using, they may have used bone marrow aspirate or PRP. And again, the data is kind of mixed on whether any of those type of biologics help them, but it's Aaron Rodgers, so why not throw everything at him, right? The other thing is you don't want to give him too much stuff in there and then cause an infection, right? Because you give him too much things you're kind of experimenting with and trying new things, you want to be careful, right? It's just a fine balance. Now, if you're Dr. Neil Alatrash doing this, you're not super worried about your reputation because you've got such a big deal. So you want to try something that's going to get them back faster, that's going to look better, right?
Yeah.
And then they're going to use that special dressing I think they had talked about that's an antimicrobial, because again, we don't want an infection, because the most common place to get an infection is right here where you had it. Now, again, probably had it done percutaneously if Dr. Neil Alatrash did it, but nonetheless, that's something to be aware of as well. So they're attacking the healing process from rigid, solid, incredibly good fixation so you can start moving early. Because remember, we talked about this. The faster you can move our patients, the better they're going to get back to. That's why internal brace works so well, because you can move them faster and test the ligament faster. That's the whole reason why it's so effective. Things don't stretch out. 2, you want to make sure you don't get an infection, so you have a special dressing. And 3, potentially biologics. So you've done everything right in the body to make it go better. And I think this would be a great topic at some point for one of our shows to kind of say, what makes things better, right? And this device, this technique, has made better. And you know where it came from, Arthrex, which we talked about before for innovation. So this is a combination of, and you could see they jumped right on it. I mean, there have been multiple Arthrex posts about this new technique in the speed bridge and really bringing light to it because it's done a little less frequently than the side-to-side repair. And it's just surgeon preference, but I've done it before and I've been extremely happy. And that's sort of the way I now fix these because of the fixation so rigid in the bone. But also I'm a proponent of rigid fixation as it is. I'm an internal brace guy, you know that. So
oh baby. And also having a smaller incision also helps with the healing process, right? I mean, I had my Achilles done years ago and I have a 6-inch scar right down my Achilles compared to the small incisions that Aaron Rodgers had for this procedure.
Yes, and that's 100%. I mean, that's why we started doing it. It was helping with healing because the other thing is when you get your whole Achilles opened up, and I don't want to gross out the viewers, but there's a tendon sheath around that has blood supply into it, and that can get damaged as you open it up and try to repair it. So, I think we go for smaller and smaller incisions not because of the idea of it's sexy, that you can do minimally invasive, but it's actually better for the patients. And the less trauma that your body has, the faster it can heal. And so that's why minimally invasive works. If obviously there's certain areas where we can't be minimally invasive, if you shatter your heel, you're not getting a minimally invasive repair because you have to open it up and get all the pieces back together and et cetera. But we are getting better and better at minimally invasive surgery. And this is one of the reasons why, so we can get people back faster.
Okay, he's talking about recovery and getting back by the end of the season. He's 39 years old. He just had this procedure. He wants to get out there by the time, playoffs start, which I don't think the Jets will be in the playoffs, but that's a whole other conversation. We're just talking about the timeline. If you were a gambling man for a 39-year-old after this procedure, for him to get back on a professional football field with 300-pound men chasing after you, what would the odds be of that?
So we've been wrong on gambling many times on this show. 100%. But I will tell you absolutely not. This is ludicrous that he was told he was 4 months. But you know what? Everybody's talking about it. It hit ESPN. I saw a big, huge article on the ESPN and talking about he's going to get back in 4 months. But again, my primary surgeries that I do are, shoulder, knee, and elbow. I do Achilles and I do this innovative technique. But 4.5 months is just a little bit too. But again, it's Aaron Rodgers. He loves to get people excited about things he says. He also was talking about things he does listens to dolphin noises to get his healing better. So we have to talk about there's different things that he's said that we don't know the credibility of. But listen, more power to him if he's motivated to get back, and he will get back. And like I said before at the very beginning of the conversation, I think he'll be back, but he's not coming back this year.
Anything that works, if it puts you in a great mental space for you to deal with your injury and think that you're recovering faster by listening to dolphins, then I'm all for it, right? Whatever gets us to our happy spot. Dr. Garcia, this is supposed to be a 10-minute show, and then we start yippity-yapping, and I've got, 85 questions, so let's wrap it up. I just want to remind everybody, please check us out at sportsdoctalk.com. Our shows are there, transcripts are there, just cool information. Dr. Garcia has tons of stuff on the website, so please check us out. Dr. Grant Garcia, orthopedic surgeon and sports medicine specialist. If you haven't figured it out, he knows what the hell he's talking about. Dr. Garcia, we didn't even get a chance to talk about our boy getting hurt, our Saquon Barkley with that ankle sprain, which is probably going to be out 3-4, maybe longer weeks. Very concerning, but hey, this is a tough sport. Thank you for your time tonight, and let's do it again.
And again, thank you so much for having me on. And again, hope both of these athletes recover quickly. Check us out on our website. And again, also, on our website, we have posts. You can post questions. We're happy to go through a show where we answer questions from our listeners. Again, it's always nice to hear the questions from Will, but the listeners as well would be great. So anything works.
Yeah, less of me and more of you. That should be the motto. That's another T-shirt. Take care, Dr. Garcia. Thank you for your time.
Thank you very much. Bye.